Start to look at the respiratory system. So the respiratory system itself, in a sense, can't really do a whole lot. It relies upon the circulatory system in order to bring the blood to it as well as take it away. So after we exchange gases in there. It needs the skeletal muscles themselves, primarily the diaphragm, in order to move gases in and out of the lungs themselves. And in order to determine when and how often and how deeply we need to breathe, we need the nervous system. So it really works with many of the other systems within the body in order for it to actually be able to do its job. And so we can divide the system up into two different portions. We have the conducting zones, and then we have the respiratory zones. And so we have this conducting portion, which doesn't do any kind of gas exchange. This is everything from the nose all the way down to the bronchioles. And then we have the respiratory portion where we actually do gas exchange. And so the gas exchange begins at the respiratory bronchioles and works its way all the way down into the alveoli. The respiratory system itself, in order to get that gas exchange to occur, we've got to inhale, and that's going to be our inhalation or our inspiration process. And then we expire, and so we have exhalation. Before that gas exchange can occur, we need to filter the air, we need to humidify the air, and then we need to warm the air. And so all of that is going to happen as the air comes down through the respiratory system and makes its way down further into the lungs themselves, and then branches and gets into smaller and smaller airways as it eventually ends up into those bronchioles. The upper part of the respiratory tract is primarily the conducting portion, and so this is the conducting airways themselves. It begins at the nose, and so the nose is our primary way for respiration. The mouth, if we breathe through it too long, is going to start to dry out. It's not meant to be breathed through for long periods of time, basically. And so the nose, the nasal cavity, we then have paranasal sinuses back into the pharynx for these areas of the upper respiratory tract. The epithelium that is there runs everything from being pseudostratified ciliated columnar epithelium, moving back into the pharynx a little bit, and into the upper part of the nose. And then we have squamous type epithelium stratified in there in part of the nasal cavity as well. This lines it, and the ciliated cells that we have there are all designed to take trapped debris that is inside the epithelium and inside the mucus that's there and move it back towards the pharynx where it can then be swallowed down into the stomach. So any kind of bacteria, viruses, anything that may get trapped in there, even dust, is going to get moved towards the back of the nasal cavity. And so those ciliated cells are going to continue to move it back and back and back until it eventually goes into the pharynx, and then it can be swallowed down into the esophagus from there. The nose itself is two separate chambers, and so we have basically two nasal cavities that are in there. They are separated by the septum. This nasal septum is created partially by the vomer, partially by the perpendicular plate, and by hyaline cartilage. And so depending upon where we are within the entire area itself, it dictates kind of what portion is covered by which one of those that's there. As we come in through the nostril, so as we come into the airway itself and get into the vestibule, we have hairs inside the vestibule that is there. Towards the posterior side of the nasal cavity itself, we have opening towards the auditory tube, or the eustachian tube, or the pharyngotympanic tube, getting us up to the middle ear, and so that'll bring us up into there. We also have the opening of the nasolacrimal duct, and so as our tears come down from the nose, from the eyes to the nose, we're going to have them travel along the nasolacrimal duct and drain into the nose itself. Bones-wise, we have the maxilla, we have the nasal bones in through here. We have the hard palate. We have part of the ethmoid bone, and then that comes down as part of the concha there. And then on the posterior side, we then have the sphenoid. The nasal cavity itself opens up into the paranasal sinuses. And so we talked about these a little bit for the bones. And those sinuses are designed in terms of the skull to reduce the amount of weight that's in the skull. But for the respiratory system, it's going to function more so with the process of making sounds. And so it's for talking. And it's going to allow the sounds to kind of rattle around inside there and reverberate around and helped with the production of speech itself that's there. All of them communicate back to the nasal cavity, and as we look through them, they all have ducts that make their way into the nasal cavity itself and come down into the nasal cavity. With the exception of the maxillary sinuses, all of them essentially drain with gravity. The maxillary sinus actually has to come up against gravity to get into the nasal cavity. And so it's going to have to work against gravity to do so. And that's part of the reason why sometimes we get sinus infections in there, because it is more difficult for them to drain out. The pharynx is divided into 3 different regions. We have the nasopharynx, we have the oropharynx, and we have the laryngopharynx. All 3 of those different regions have a little bit different purpose as far as they go. The pharynx, in terms of those areas, the nasopharynx portion is the only portion that is basically designed for air only to move through it. And so the nasopharynx is going to be limited to air only. Both the oropharynx and the laryngopharynx have the ability to allow for both air as well as food and liquid to move past through them. And so the lining of the walls themselves are going to be slightly different depending upon where we are within those. So the nasopharynx is the most superior portion that we have. This is for air only, and so only air is supposed to pass through this area that's here. This is going to be one area where we start our first kind of protection to the respiratory and oral cavity. And so we have tonsils in this region here. So we have our pharyngeal tonsils that are there. Both the auditory tubes, so our pharyngotympanic tubes, as well as the openings up to the middle ears are draining down into this particular area as well. And so that's going to have drainage down into this area. And that's again where things like infection can make their way from an upper respiratory tract infection and migrate themselves into a middle ear infection. The middle area is the oropharynx. And so the oropharynx is now both a respiratory and a digestive region. So both air and food and liquid is going to be able to travel through this area, which means that we need to have a little bit extra protection in this area itself. And so we're going to move away from that pseudostratified ciliated columnar epithelium down into a stratified squamous epithelium, so that we have that extra protection for the food that may be coming past here. We pick up the palatine tonsils, and so the palatine tonsils as well as the lingual tonsils are both going to appear towards the back of the throat. The laryngopharynx, we have the most inferior portion of it, and essentially this is going to be the place where we decide kind of where things are going to go. And so with this area here, we have the laryngopharynx designed for air to go into the trachea, to go down through the larynx and into the trachea. And then we have designed for food to go down into the esophagus itself on there. And so we have our stratified squamous epithelium. We have protection from food that's going to potentially cause damage in this area. The larynx is what's going to determine whether we go into the trachea or whether we go into the esophagus. So continuing into our conducting areas themselves, we have the larynx, and then we're going to move into the trachea and then into the bronchi. And so multiple branches of the bronchi themselves, and then down into eventually terminal bronchioles before we hit into the respiratory bronchioles for the respiratory portion. and then from there into the alveolar ducts, and then into the alveoli themselves, where we do the majority of all of our gas exchange. So the larynx itself sits essentially in the neck. This is the first portion of the airway that isn't really protected by any kind of bony structures. And so this is made up essentially by cartilaginous structures. And so it has a large amount of cartilage. So 9 different pieces of cartilage make up the entire larynx itself. Some of that cartilage is movable. And so we have the ability for the epiglottis to move. We have the ability for our cartilages around the vocal folds to be able to move. And one of its jobs is the production of sound. And so this is where our voice begins at, down in the throat itself. That's there. We're going to make sure that whatever comes into the larynx is all air, and that's going to allow it to essentially be closed off by the epiglottis. So when we go to swallow, we're going to close off the larynx from that food that's coming down by closing the epiglottis over the larynx itself to the opening that's there. And that epiglottis is basically surrounded by the thyroid cartilage on either side of the sides. And so the 2 lateral sides, and then along the anterior portion as the thyroid cartilage as well. The posterior side is essentially open, and that's where the epiglottis is going to fold over. We have a couple of additional cartilages that are paired as well. The arytenoid, the corniculate, and the cuneiforms. These all are attachment points towards the posterior side, where we're going to have our vocal ligaments, or the vocal folds, attach into them. We do have 2 sets of vocal folds. Those 2 sets of vocal folds are the true vocal folds and the false vocal folds, or the vestibular folds that are there. And so the true vocal folds are going to vibrate, and they're going to produce sound. The false vocal folds don't actually approximate one another. They don't come together and touch one another at all. So they can't vibrate whatsoever. So they don't produce any kind of sound that's there. By varying the tension and the length of those vocal folds, we determine essentially the pitch of the sound that we're going to create. And so here we can see the true vocal folds. And so the lighter area that's there. And then the false vocal folds, or the vestibular folds that are there as well, are the outer ones. And so drew that one a little bit too far. So the outer ones here are the false vocal folds. They won't actually end up touching one another. So when we do go to make a sound, those true vocal folds start to approximate one another. They start to come together within the larynx itself. Some other ligaments that we can see here. So we see the big shield-shaped thyroid cartilage. The thyroid cartilage is not a complete ring. It is completely open. We can see the 2 lateral sides here on the posterior aspect of the larynx. And so it does not make a complete circle. It's opened on the posterior side. The cricoid cartilage is the only cartilage that actually goes all the way around. This is said to be a signet shape. And so it looks like a signet ring, or signet style of ring. It does make a complete circle, and so it's going to be the one that basically limits the size of air that can, or the amount of air volume that can come in and out of the larynx itself on there. On the posterior side, we then have our arytenoid cartilage, and sitting on top of the arytenoid cartilage, we have the corniculate cartilage. It's kind of getting tight in there to be able to see there. And then just above that, we have the cuneiform cartilage. So depending upon whether we are speaking or just breathing is going to dictate how those vocal folds are approximating one another. When one is just simply breathing in and out, those vocal folds are going to stay relatively spaced apart from one another. So they're going to be moved apart from each other, so air can just simply move in and out. When we want to go do phonation, we want to make a sound, we're going to pull on those arytenoid cartilage. The corniculate cartilage and the cuneiform cartilage is going to move with it, and that's going to then allow for the vocal folds to start to approximate one another, and then they're going to vibrate as we make a sound. And so here we can see laryngoscope views, And so once again, here the person is just simply breathing. Here the person is making sound. And so they're starting to make a tone with their vocal folds. So they need to be approximated to one another. And they're going to vibrate similar to that of like a reed in a saxophone or a clarinet. From the larynx, we move down into the trachea. And so the trachea is then going to be our next portion. This is essentially going to be our pathway to get us from the neck all the way down to the lungs. And so the trachea is a long tube. It has tracheal rings in it, and so we have tracheal cartilage that's there. Those C-shaped cartilage, similar to that of the thyroid cartilage in terms of the design there, they are open on the posterior side, so we can see that cartilage here, and we can see that it goes almost all the way around, but it is still open back here in the back on those. Depending upon the length of the person's torso is going to dictate how many of those cartilaginous rings they have that are there. And this, once again, because we don't have any bony structures to help to hold the airway open, this is going to make sure that that trachea stays wide open and we're able to breathe at all times on there. We do have some ligaments associated with it as well on there. And so we have the annular ligaments in between each of the cartilage. So that runs in between the cartilage themselves on there. On the posterior side, we have the trachealis muscle. The trachealis muscle is basically in between the esophagus and the trachea itself. And so here we have the esophagus running behind that. From the trachea, so the trachea comes down and then it's going to split. And when it splits, the very last cartilage that's there is an important one because it's kind of a Y-shaped cartilage. It's going to split the two into either side there and allow for us to go into the primary bronchi, which are going to enter each of the lungs themselves. And so we have a primary bronchus, which gets us into the lungs. The primary bronchi then split into secondary bronchi. The secondary bronchi are going to be determined by the lungs themselves. And so since the right lung is going to have 3 lobes and the left lung has 2, we then have 2 secondary bronchi on the left and 3 secondary bronchi on the right. Again, those secondary bronchi then start to branch some more. And so we have now tertiary bronchi, and those tertiary bronchi then split and split and split and go into the smaller regions of each of the lobes themselves. From there, they can continue to branch smaller and smaller until we get into eventual bronchioles. If we were to flip a person upside down and start to look at the branching themselves, we would see that they start to branch and branch and branch and branch, and it really starts to kind of look like a tree. And we go into smaller and smaller and smaller branches as it goes, and that goes out into the lungs themselves until we're out into the smaller bronchioles and getting into our respiratory portion. So flip the image upside down, and it really looks kind of like a tree as it comes in. And so the trachea comes down. We get to that last cartilage of the trachea, the carina. That then splits us into a primary bronchus on either side. Those primary bronchi then split into secondary bronchi. And then from there into all the smaller tertiary bronchi as we're going into the smaller airways themselves. And so the lungs themselves kind of look like big sponges when we look at them inside the actual lungs themselves. When we look at the individual lungs, we can see where the primary bronchi enter into the lungs via the hilum. And so we have the openings for all of our blood vessels and the bronchi themselves. And so arteries and veins entering and exiting through the hilum of the lungs. The lung has an apex, similar to that of the heart that we talked about. And then it also has a base. And so the base is once again on at this point, it's actually on the lower end. And so this is the part that is going to be touching the diaphragm. So this is the part that's going to run along the diaphragm itself, along the bottom there. Each of the lungs is split into their lobes, and so the right lung here has a superior lobe, it has a middle lobe, and then it has an inferior lobe. The left lung only has two lobes, so it has a superior lobe, and then it has an inferior lobe. Those lobes on the left lung are separated by a oblique fissure. On the right lung, because we have three lobes, we do have an oblique fissure, but then we also have a horizontal fissure. And so that's going to separate us into our three different lobes that are there for the lungs themselves. From the terminal bronchioles of our conducting zones, we have the respiratory bronchioles beginning our portion of the respiratory portion. And so we have the respiratory portion of the lungs beginning at the respiratory bronchioles. We then move into the alveolar ducts and then into the alveoli. And it's in the alveoli where we're going to do the primary gas exchange for the lungs themselves. The bronchioles do have the ability to both dilate as well as constrict. And so they can go through bronchodilation and bronchoconstriction depending upon what is going on, in a sense, in the body itself. And so if we're under a sympathetic response, we're going to get bronchodilation. We want the lungs to get as much air into them as possible. If we're on a parasympathetic, rest and digest type of a response, we're going to get bronchoconstriction. We don't need as necessarily air coming into them. So here we have our terminal bronchiole coming into a respiratory bronchiole. So that's essentially the dividing line between that of the conducting zones and the respiratory zone. From there we come down through a alveolar duct, which then splits out into individual alveoli and an alveolar sac. And so these kind of look like a bunch of grapes. And so they have the appearance of kind of having a bunch of grapes to them. They've got kind of a central stem, which would be our alveolar duct. And then from there, they break open into a whole bunch of them, which are the alveolar alveoli themselves, and they are all part of an alveolar sac. Millions upon millions of alveoli increase the surface area of the lungs, which allows us to have a huge amount of gas exchange occurring within them. When we breathe out, and especially if we breathe out forcefully, the alveoli want to tend to collapse in on themselves. They reduce that, in a sense, need to collapse in themselves because of a substance called surfactant. And so surfactant is essentially a substance that reduces the surface tension of water. And so inside the alveoli, we have a whole bunch of fluid. It's not that it's filling the air sacs or anything, but the fluid is on all of the surfaces. And just like when you are in a science class and you go to measure a liquid, we'll make it a green liquid. When you go to measure that liquid inside your graduated cylinder there, you look for the curve of the water as it comes up the wall. And so we can see that it curves up, and we're going to measure the line at the bottom. So this is our meniscus. So we know that water likes to kind of stick to other things. So if we were to allow those alveoli to just kind of collapse in on themselves, they would literally collapse the lungs. And we don't want that. And so that's where the surfactant comes into play in order to reduce the amount of kind of stickiness of the alveolar walls. Inside the alveoli as well, we also have phagocytic cells. And so we have macrophages that are kind of wandering around, cleaning up anything that shouldn't be inside the alveoli. And so here we can see those alveolar sacs on a microscopic view. We looked at these back when we looked at the histology. This was our simple squamous epithelium. So all of those individual little layers that are there are the simple squamous epithelium lining the inside of the alveolar sacs themselves. So we have a couple of different kinds of cells. And so we have lining cells here that are inside the alveolus itself. And so these are our type 1 cells. So these are kind of lining the whole inside of the alveoli. And then we also have type 2 cells. Those type 2 cells are the ones that are making the surfactant. These are the ones that are producing the surfactant that's going to spread over all of the little alveoli. And then here we have our little alveolar macrophage wandering a lot around looking for antigens, looking for bacteria, viruses, dust, debris, whatever is not supposed to be in our lungs. Those simple squamous epithelium make it so that we have a very thin cell. And so we have a thin wall. We just have the cell wall to get through for gas exchange. And then we have the cell wall of our capillary to get through as well. Both of them utilize a squamous type cell. And so very, very thin cells. And this allows for the very quick diffusion of oxygen in and carbon dioxide out. And so this allows for us to get those substances to move very quickly through the linings. So we did most of the gross anatomy of the lungs on the other picture slide there as well, but we'll just quickly review. So we have the apex of the lungs. We have the base of the lung, the curved portion on the bottom where the diaphragm is going to be as well. Both lungs have an oblique fissure. And then the right lung has the additional horizontal fissure that's there because the right lung has a superior, a middle, and an inferior lobe, whereas the left lung only has a superior and an inferior. And so two different sets there for that. The heart itself is going to be right in here, and that's going to create the cardiac notch in the left lung. So there's going to be a little bit of a space that's needed in a sense for the lung itself that's there. Just like all the organs that we've talked about before inside, they are covered over by a serous membrane. And so that membrane covers the lungs themselves. That's there. And so we have a visceral pleura that's going to be right over the surface of the lung. And then we're also going to have around the body wall, we're going to have a parietal pleura. And so that's going to contain the lung. Each lung has its own parietal pleura that surrounds it. And so if one lung should happen to become damaged or deflated, if we get atelectasis in one lung, we can still function to a certain degree with just one lung being inflated. Breathing is certainly going to be more difficult, but it does have the ability to continue to function. So here we can see that parietal pleura on the outside, the visceral pleura on the inside, and a little bit of gap in between. That little bit of a gap is the pleural cavity, and that pleural cavity again is lined with a tiny bit of fluid, and that helps to lubricate the lungs inside the chest wall itself. And so the lungs are going to be able to move basically friction-free inside the thoracic cavity. And here we can see an actual view of it. That shiny portion that is covering the lung itself is the visceral pleura. We can't really see the parietal pleura here. It's going to be along the chest wall there itself as well. But it is there, and we have the ability to then see that space that's there as well in between in that pleural cavity. For the production of gas moving in and out of the lungs, we have Boyle's law. And so Boyle's law basically comes down to having P1V1 equals P2V2. And so the pressure and the volume in our first scenario have to equal the pressure and the volume in the second scenario. So what's going to happen is that as we breathe in and out, the chest cavity itself is going to become either larger or smaller. And so if we go from having breathed out, so to having done exhalation, when we want to breathe in, the volume inside our chest in V2 is going to go up from where we were before. And so if our volume goes up, that means our pressure is going to have to go down. from where we were initially. And then just the reverse is going to happen for exhalation once that occurs. And so essentially what it comes down to here is that we have inhalation, we have changed the volume here to be a larger volume. And then for exhalation, we make a smaller volume inside the chest cavity as well. And so in this case, we have P1 V1 equals P2 V2. And with that, in our exhalation, now that our volume has decreased, that's going to make our pressure increase. And so that means that we have now higher pressure inside the thoracic cavity, and that's going to push the air up and out of the system. And so this is going to force the air out of the system itself. For our inhalation, in a sense, we have our P1 V1 equals now P2 V2. And now all of a sudden we make our volume that we have is going to become larger, which means that our pressure decreases, which means that now air is going to want to be forced into the lungs. So we have a lower pressure inside the lungs compared to the outside of the body, and that forces the air in. It goes from a higher pressure towards a lower pressure. So here we have a lower intrapleural pressure and an intrapulmonary pressure, and so the air gets drawn into the lungs. Here for exhalation, we have a higher intrapulmonary pressure and intrapleural pressure, and that's going to force the air out of the lungs. For breathing to occur, we primarily use the diaphragm. But when we want to do forced inspiration or expiration, we're going to use some extra muscles. Some of these muscles are going to be in between the ribs, and we have what we call intercostals. And so we have a set of external intercostals, and then we have a set of internal intercostals. The external intercostals help with inspiration, and so they're going to be helping with inhalation. The internal intercostals help with exhalation. For exhalation, normal restful exhalation basically doesn't require any kind of muscular effort. It doesn't require us to use anything other than to let the lungs that had been stretched out and the rib cage that had been pulled up to just relax. And that's going to force the air out of the lungs. It's kind of like if we blew up a rubber balloon and we didn't tie it and we just let go of the end, the higher pressure inside the balloon due to the elasticity of the rubber balloon is going to force the air out. And the same thing happens with our chest. The elasticity of the lungs, the elasticity of our thoracic cage forces that air out of the lungs. Inspiration, however, is a very active process. This requires muscles to become activated. If we really want to breathe deep in, we're then going to activate some other muscles in addition to those external intercostals and the diaphragm. And so we're going to activate in the neck things like the scalenes. We're going to activate the sternocleidomastoids. We're going to activate down around the chest, pectoralis minor, and serratus anterior. And all of those are going to help with forced inspiration. So inhalation, we have the diaphragm, we have the external intercostals if we need them. We have the scalene muscles, sternocleidomastoid, pec minor, things like that. For expiration, we have, for forced expiration, we're going to use the internal intercostals as well as abdominal muscles to help to force the diaphragm up even further. Control of ventilation, so control of our breathing in and out. For the most part, when you're not thinking about breathing or talking or anything, you don't really think about the breathing process. It's all under unconscious control. And so it's involuntary in terms of the process. We can consciously take it over at times whenever we want to, but ventilation itself is generally going to be an involuntary process that's going to occur. This receives signals in terms of the diaphragm, gets its signals coming down from the brainstem, and so we have a ventral respiratory group, and then we have a dorsal respiratory group. This is going to deal with our inspiration and our expiration. Ventral doing our inspiration, dorsal doing our expiration. That's there. The pneumotaxic center, part of the pons up here, is going to be dealing with when to essentially inhibit inspiration as we breathe in more and more and more and more. It's going to eventually inhibit the process itself and turn it off.